Hello, everyone. Welcome back. I am Vindi Singh with the Global Fund, Dr. Lazarus Momanyi from NASCOP in Kenya, and I will be chairing this pre-conference session. In this session, presentations will focus on enabling required service delivery model transitions, either due to a change in the population group or increased or reduced intensity of clinical management. Great strides have been made in terms of scaling up DSD for HIV treatment models. However, there are times when people are at risk of interrupting treatment, including during periods of transition. In this session, presentations will focus on enabling required service delivery model transitions, either due to a change in the population group or increased or reduced intensity of clinical management.
Thank you, Vindi, for that introduction. I would like now to introduce our speakers for this session. Our first speaker will be Ms. Lynn Wilkinson, a technical consultant with the IS and a research associate at the University of Cape Town. Lynn will be present to us about enabling successful transitions within DSD for HIV treatment. The next speaker is Stanley Ngoma from the Ministry of Health in Malawi. Stanley is the focal person for differentiated service delivery models of care, and will be presenting to us about supporting HIV care during adolescent to early adulthood. Our third speaker is from the Ministry of Health in Uganda, Dr. Cordelia Koturebe. She's a pediatrician and a child health specialist with over 15 years of experience in clinical care, strategic planning, and implementation of programs addressing HIV care and treatment for pregnant women and children. Dr. Koturebe will be presenting to us on moving between DSD models as needs change. The next speaker is Helda Makal, who is from the Ministry of Health in Mozambique, who will be presenting to us on managing elevated high viral loads within a group DSD model. Helda is a technical advisor for care and treatment and a focal person for DSD at the National STI and HIV AIDS Control Program in Mozambique. And last but not least, our last speaker will be Ms. Lilian Moreko, who is an executive director and a founding member of the International Community of Women Living with HIV, Eastern Africa, and she'll be presenting to us on DSD before, during, and after pregnancy. We look forward to an exciting and an engaging discussion. Welcome.
I think most people are back. So good morning. This morning I'm going to be orientating you around critical service delivery transitions and how which interventions we can use to facilitate effective or what we hope to be seamless transitions for our recipients of care. Just building on the last session, I want to take a minute to reflect on where we are at the moment. So we know for our adults established on treatment that access for DSD is now widely endorsed in global policy, incorporated in national policy, and we have scaled implementation that was accelerated during COVID. For our special populations, and here I'm talking about children, adolescents, pregnant and breastfeeding women, and for key populations, we also see global policy endorsement, especially in the WHO 2021 update. We see increasing adoption in countries except for pregnant and breastfeeding women, which we'll speak a little bit more about later. And we see scale, though, lagging behind, although we did see a quick kickstart during COVID, and we hope that this will continue. The last group, we have increasingly feel that DSD may benefit groups that are not established on ART, and we will speak a little bit about those today. So people who are in their first 6 months of treatment, people with viral rebound, and then perhaps most importantly, people that are re-engaging in care, and we need to see that we can try and update our policies and get implementation going in this arena. While we develop our DSD strategy, we also start to realize that there are existing or perhaps new weaknesses within our DSD systems that require our focused attention. Critical to DSD are DST transitions. So events that necessitate us moving from one differentiated service delivery model to another model. And those are what I'm going to be talking about today: age, pregnancy status, clinical stability, and patient or recipient of care preference or the availability of models at facilities. Here you will see reflected the type of events that I'm speaking to. So in the orange age block, we're talking about adolescents as they age potentially into young adulthood, or adults that age into becoming an older adult. For our light blue block, we're talking about pregnancy. So a woman who may have completed her pregnancy, but now is a mother in a mother-infant pair. In our purple block, the one that we probably deal with the most frequently is when a patient's clinical stability changes. So either they were well and now become unwell, or someone with viral rebound regains a viral load suppression. And the last category in the bright blue block is focused around patient preference. Now, patient preference might be driven by actually deciding I want to change a model from, for instance, a facility model to an out-of-facility model, or might be necessitated by change in circumstances. And we will hear later in the next session how much of our disengagement is driven by mobility and therefore patients having to move facilities and therefore having to change DSD models. So we can broadly encapsulate or broadly describe these transitions in three broad categories. The first are transitions from more intensive to less intensive models. That might be for the first time when you first get assessed as virally suppressed, or it might be when you come back into a less intensive model after a period of increased intensity. In the orange arrow, we talk about people moving between less intensive models. These are usually necessitated by a change in age or a change in choice. And the last category in the light blue upward arrow is when somebody moves from a less intensive model to a more intensive model, usually due to a psychosocial or clinical need. Within transitions, we have risk. A patient may not be ready for that transition. The recipients of care might not have had it explained appropriately, may not have fully bought into the fact that they need to change their model, and they may perceive that they're losing something that they really value in their existing model. The health system, while facilitating these transitions, may not be set up properly to make sure that it works properly. And we see this where, for instance, we give longer refills, but our drug supply system is not able to actually provide that length of refill. So someone arrives for a 6-month supply, but actually is short supplied, or their drugs don't arrive at the new location. And these all mean that we have an increased risk of our recipients of care being unhappy with the transition, unhappy with their new DSD model, with an increased risk of treatment interruption and disengagement in care. And so we really need to step back, look at these service delivery transitions that are so much part of DSD, and work out how we can facilitate ensuring that these are seamless and accepted by our recipients of care. I'm going to speak very briefly, and then my colleagues will speak in a lot more detail about the interventions across these three broad categories of transitions that facilitate transitions and that we should start considering in our DSD policy and in our implementation. The first is, as I said, the first category is this transition from intensive to less intensive. And the most obvious examples are in the left-hand blue arrow. So that's when you first assess for eligibility, when you return to clinical stability, or after a period of disengagement, so at re-engagement. And we know that one of our weaknesses, and really that we need to strengthen, is what we call DSD treatment literacy. The more our patients understand about their DSD models and the options and how they function, the more likely somebody is going to accept the transition that they've made. And so we do need to invest in increasing that literacy. For children, there's good evidence to show that we should allow children to be in the same less intensive model as their caregiver or their family. Even if the DSD policy doesn't support as a flexible ARV refill timings or clinicals, we really need to make as much as possible that those two are aligned. And we see a great example in the Kenyan policy where despite children not actually qualifying or being eligible at a certain age, if they have a caregiver that's in a DSD model, they automatically do qualify. And we need to think of similar interventions. For our adolescents, we know that our less intensive models that enable peer support and group networking are important, and my colleague Stanley Ngoma will speak about the Malawi experience. For re-engaging patients, these are patients that were not in less intensive models before. We need to examine whether the disengagement was driven by healthcare burden and how quickly we can accelerate DSD access for patients on re-engagement and increasingly incorporate within countries' DSD policies algorithms that make it clear when a re-engaging patient can access less intensive DSD models. We already see this in South Africa, and we will see it in the 2022 policies for Mozambique and Zimbabwe. When patients transition back into care, when patients transition back into care, we need to make sure that it is explained to a person when they will be reassessed for their less intensive model, say 3 months, and what will be required if a viral load assessment is required, and that they are then able to re-access the same model they left. So we see increasingly that people then get re-enrolled in a different model and don't have the access to the already established group network or peer support which they had before they left the model. For transitions between less intensive models, for children and adolescents, there's good evidence, and we'll talk a little bit about that later, that we make sure that children and adolescents are orientated about the transition, that we plan that transition with them, and that we carry out individual assessments to see that they're ready for that transition. For children, adolescents, and postnatal women, there's evidence to show that those transitions should be gradual. They shouldn't be abrupt, where I turn 19 and tomorrow I go to the adult clinic, but actually that we incorporate some elements of the new model or the older model into the existing model. A longer refill, introductions to the new healthcare provider, introductions to the new location, so that transition is facilitated, and that we consider cohort transitions. That's allowing a number of members to transition at the same time into the next model so that we actually keep together that already established network of support and the person doesn't transition on their own into a foreign space. We already heard in the previous session that we want to regularly assess someone's DST service preference. This should not be something that's only done once off when assessed for eligibility, but regularly, hopefully annually in the clinical consultation. And my colleague, Cordelia Katerebe from Uganda, will speak about how Uganda has built this into their DSD approach. For patients with mobility, and we see how big the scale of mobility is, we need to start at a country level considering our DSD mechanisms for allowing patients to switch their less intensive model without having to first go to a new clinic into a more intensive model, then re-qualifying for a less intensive model. We see some early examples. The CCMDD system in South Africa allows the recipients of care to choose an alternative external pickup point, but this is not widely known or utilized, but a good example of what we can start thinking about. And lastly, our up referrals. These are transitions from our less to our more intensive models. We found from the qualitative evidence that recipients of care are often very upset about these transitions, feeling that they're punitive, and that this could be helped by improved healthcare provider, recipients of care communication, so that there's some value ascribed to the increased clinical management or increased psychosocial support provided to the patient for the period of intensity, and they also know when they're going to be reassessed for their less intensive model so that they can get back into easier, simpler care closer to home once they're ready to do so. Our way forward then is to focus on increasing our DSD treatment literacy to support these transitions, improve our service delivery transition communication between our healthcare providers and recipients of care, consider in our DSD policies our facilitators and enablers for these transitions, ensure that our specific population DSD models also cater for how you transition out of that model. If your DSD policy allows for youth clubs, what happens when that person is no longer a young person? How do they transition out? And while we can't deal with every transition, we start with the ones that are impacting our outcomes the most and make sure that we have a plan in place for enabling those transitions. Thank you very much.
Thank you so much, Lynn, for that presentation. And now I would like to usher in Stanley to make a presentation around supporting adolescents and early adulthood. I would like also to just remind our audience, please submit your questions about the online and the physical audience, and we'll be able to post some of these questions to the panels. Thank you. Welcome.
Thank you, moderator. So I'm called Stanley Ngoma from Ministry of Health, Malawi, and thank you, moderator, and everyone else for having me to introduce and talk about the transitional strategies that we have for our adults that are being moved into early adulthood. So I have no relevant financial relationships with ineligible companies to disclose. So in regards to the implementation of various DSDs, Malawi, specifically for teen clubs, we've got different funding models, starting with PEPFAR, Global Fund, so with PEPFAR through different agencies, and they're implementing partners across the countries in the district of support. And we are talking about different categories of recipients of care that we actually serve in various DSD models. So specifically for teen clubs, we are reaching out to the established and unestablished recipients of care within the model. And with this guideline that was released in 2021 by WHO in March, for definition of the stability, it's been revised and is cutting across all the population groups, and also considering those in different treatment regimens from first line, second line, and also third line treatment regimens, and all the population groups that are on the list there. And there are different needs actually that we need to meet to the teens that we serve in these models. And we have actually to factor in the times because of different places where they would be at different times, and also the place, so it should be flexible for them, that they should be able to access the services and also the appointments. So the systems should be there actually to save and accommodate them. And in terms of HIV care that we need to provide, it has to be much more comprehensive and extending to the sexual and reproductive health services that have to be reached out to them, because there are different packages that are offered at different age bands within the teen age. And we have to actually monitor them closely within the cascade of being teens in that model, so that they're actually engaged in care throughout, and also get some strategies in case they get disengaged from care, so how they would be re-engaged again. So we achieve all the 95-95 treatment targets. So there are different models at which each of the services can be offered. So group models, which could be facility-based, as well as also community-based. So example, facility-based could be like the teen, and we also have got some familiarity refuse, and then extending to individual models. We also have got some adolescent corners and the youth services that could also be offered to them. And in the community, you could go as far as the outreach and youth center pickup points where they can also access their HIV services. So we've learned from several other models across the globe, and just reciting an example of the genre, which is an approach that most of the countries actually getting into when it comes to service delivery. So focusing on facility-based refuse or provision, as well as community-based. Like, for example, we've got countries like Zimbabwe and Uganda providing the CATS and YAPS model respectively. Specifically for Malawi, we adopted the teen club model that was developed by Baylor International Pediatric AIDS Initiative in 2003, but getting to Malawi in 2007. So we also adopted that model, and it's actually being implemented in most of the districts and that are supported by different partners. And it offers comprehensive HIV services integrated with sexual and reproductive health. And we offer such services over the weekend, and mostly it's like every 2 months when they come to the facilities to have their refills and reviewed for every health care comprehensively, like I mentioned before. And they have to meet the criteria of being teens, so in the age range of 10 to 19 years, and they should be fully disclosed. And also with guardians, they should give a consent that their kids could get into such models. And currently, we've got 369 teen clubs in Malawi, and 35,000 teens within the national cohort are retained in care, and they're actually eligible, and they are into the teen attending these clubs with a greater retention of more than 90%. And a viral suppression rate of more than 78%. So most of the teens, most of the children that we see in the teen clubs, they have actually been transitioned to a pediatric DTG regimen with more than 10 IPs that are working and supporting the implementation of these models in districts. So it's actually extended beyond the teens, the 10 to 19. We've actually included some of the models that are even less than 5 years of age, so the kindergarten ART model. But like I mentioned before, for each of the age band, there are different services that we actually offer. So on the right, there's just trying to illustrate in terms of what should be offered or what we are offering. So, for example, 3 to 9 years, the major emphasis is on disclosure and adherence, and then 10 to 14, adherence and also nutrition support, 15 to 17, sexual and reproductive health, whilst 18 to 19, this is where we try to put on the preparations and prepare our teens into early adulthood once they go beyond 19. Okay, so these are just some of the models and activities that happen during their visits, basing on their age. And on your right there, you get one of the activity mostly during the graduation as they're getting transitioned into early adulthood, joining other DSD model on those age groups. We have experienced some challenges in regards to the transition. These are categorized into individual and also health outcomes as well as the health system challenges. So fear of unknown, kids, they don't feel comfortable to be out of the teens and leaving the DSDs where they work. They feel better working with their peers, and also there are lay cadres that provide support along the continuum of care, and also often they lose integrated care that I talked about, HIV and sexual reproductive, and qualitative studies have shown reduced satisfaction after transition, so they are not happy actually to be outside the teens. In terms of the outcomes, retention has been challenging, and also with the high viral loads and low CD4. And also on the health systems, they refuse basically to be out of the teens, and a number of teens to service in adolescent DSD models, and also introducing greater age disparities within the adolescents outside the models. So despite these challenges, we can do better, and the suggested approaches, development of clear country level plans that should be offered to the teens during the time we're preparing them for transition, and also assessing them in terms of their readiness after we've actually provided some sessions or retention sessions. And like Malawi already, what we are doing, we've got some teen mentors within the clubs that are supporting the teens the time they are being prepared to be transitioned from age 18, and sessions that are actually happening across, and they are assessed actually for readiness. Another area, it's this thing has actually to be gradual. So like I mentioned before, 18 and over 19. So they should be exposed to new service delivery after 19 years of age, so where the new site where they have to access their services, and some components also that will be included in the new service model that will be actually getting, so including the longer refills, and also focused peer support pre and post transition. So this is already a process that is actually happening in Malawi in some centers, but we are scaling up gradually. And in terms of the cohort, so we are transitioning more than one. So we've got some sessions like ceremonies, graduation ceremonies, as we transition them. And they are being leveraged to establish peer network beyond the teen clubs in the general community. We've got some community-based organizations where they are linked, and they are linked to health facilities where they access the services. And we also have to identify enabling adult group models at the same facility where they get attached to it, and scheduling for individual DSD model, but on same day at the same facility where they can be accessing the services. So we have some peer leaders that are actually oriented and they support the health workers in terms of running of such CBOs. In terms of the services, the challenges, basically we are on the move to expand our DSD model, especially for the teen, but we are limited because of the funding that is currently available from Global Fund and also from paper through the partners, and with limited partners that are actually supporting, and also capacity, and also some limited number of facility within the CACs and community support groups run by community-based organizations, and also some challenges with the buy-in among the staff, reduced clinical consultations. And M1E system is also challenging to keep track of the outcomes for these children that have been transitioned into early adulthood. In terms of way forward, we have actually planned to develop a simplified transition plan or approach so that they are our kids, once they get into early adulthood, we continue engaging them in care, or if they disengage, we need to find strategies on how they can be re-engaged and get back into care. And this will be piloted by some partners within the MOH, and also engaging some research partner to follow outcomes after the transition, because this is very, very important. So thank you for listening. These were the few slides that I had to present this morning.
Thank you so much, Stanley, for that presentation. And now I'd like to welcome Cordelia from Uganda to talk to us about moving between DSD models as needs change. Welcome.
Good morning, ladies and gentlemen. My name is Cordelia from Uganda, and I coordinate care and treatment. This morning, I will be talking about moving between DSD models as needs change. This slide is really to give us a background of where Uganda and other countries have probably come from in terms of demonstrating the dynamic nature of DSD, and also as we progress towards providing patient-centered care. In Uganda, we had the adoption of the DSD guidelines, following the WHO guidelines. We have been able to develop training curricula to guide how these guidelines will be implemented. We have had issues around eligibility criteria, and we have seen from the presenters this morning how stability and how eligibility criteria keeps on changing over time. We have had issues around fixed and flexible models. And in Uganda, we believe that every person, every recipient of care should be in a DSD model. The issue would be which approach is accepted more by the client. And we are now seeing, come 2021, in the WHO guidelines, we are seeing more flexibility around DSD. And as countries, how are we going to be ready to adapt this and to look at how recipients of care move from one model to another? At the background of all this is the 4 building blocks, and I think already some speakers have talked about this, that we need to determine when, where, what, and who as we try to do patient-centered care. When we talk about innovations, as we get into the topic, the WHO guidelines have given us clear guidance now. I think it's getting clearer and clearer. about how to categorize recipients of care. And if anyone looked at that criteria of about five different categories of recipients of care that will at any one point come into a clinic. In Uganda, we have gone ahead to try and see how we are now able to improve the approaches of care that we have based on group models and individual models. And this is because people living with HIV, in terms of how they live, is really a dynamic nature, and therefore we need to look at the flexibility of models. And we need to see how we are able to move recipients of care from one model into another, and also taking advantage of all the different models. The diagram on your left will show what we are doing in Uganda as to how we are able to manage the group models and also the individual models. But most important is that we've provided a rich menu of the different examples, as you'll see in the slide, to be able to capture every approach for every individual that will possibly come. We've also allowed for innovation to be able to capture data on any other models or any other approaches that have been identified by the facilities. So the question now is, how are our systems as Uganda and other countries, our systems for counseling, how are our systems for information systems to capture data, visualize data, how are we able to track these and demonstrate these innovations? So we need to look at some of the facilitators for transitioning. Like I mentioned, we had inflexible models before. We were inhibited by issues around age, viral load, pregnancy status. And WHO has now opened this up for us to look at individuals as they come in and being able to determine what state they're in. So we see that those barriers around age, viral load being taken away. When we get to the health information systems, and I would like us really to dwell on this slide, we need to be looking at, as we change the different models, are we ready to share this information? How do we capture this information? And the first one is how we visualize data. In Uganda, we have a dashboard that gives us real-time data right from the health facility on how we are able to capture patient-level data around which model of care, which approach of care, and we're able to look at the numbers real-time and at facility level. The other important aspect I wanted to bring out is the 5As approach, which has really a long-term evidence-proven counseling framework. And we picked this framework from the counseling and applied it to DSD. And in here, we are saying at every contact with a client or with a recipient of care, you want to do what we call the 5As. We want to assess the recipient of client's knowledge about DSD. And I think the previous speakers have talked about this. How do we have that engagement in terms of treatment literacy to be able to provide information, education, and communication to our recipient of care so they're able to make an informed choice? How do we assist them to identify what are the possible barriers and what will facilitate them being in an approach or a model of care? How do we advise as healthcare providers? And then how do we agree and then arrange? In this way, this is a process that is done at every visit for a recipient of care. And the question now would be, how is this information put into our information systems? So in Uganda, we have our HIV care card. This HIV care card is our tool that we use as a primary tool for data, but we also use it to support care for the recipients of care. And at this point, after that counseling through the 5As framework, we now want to be able to categorize where every recipient of care would fall after agreeing on a model that has been preferred by the client. And we can see in there we are able to look at the categories, be able to look at the model, and then be able to pick out which approach. In this way, as a country, we are going to be able to demonstrate what approach has been chosen, and we are accounting for every recipient of care. And most important is that we should be able to measure the outcomes of each of the individuals, and as a program, we are able to have individual data. It comes with challenges. Of course, how do we counsel and document the effect of counseling on the primary tools? And I think this, for me, is a talking point in this meeting. How do we ensure that data is captured, translating it from a counseling, from a dialogue, to a primary tool where we are able to get the data? We have issues around the stability criteria, and I think in these engagements we need to decide what would be eligible, how do we open up DSD that the recipient of care has full, they are able to determine for themselves what model of care they would want to belong to, and what's the win-win situation between the health system and the recipient of care in determining that. And of course, there are some challenges around the social norms where we still believe that care is best at a hospital and not in the community. How do we still go around that? So our way forward, therefore, is that we are modifying the recommended available DSD models to fit into the scope of the region or the district. We have to be mindful of the context. And therefore, our service delivery approaches in terms of counseling, in terms of the tools to collect data, in terms of how we report and how we look at the program will have to be modified. The expansion of the eligibility is a definite yes. And probably it's not about eligibility for DSD, but eligibility for an approach. Every person should have the right to be in a DSD model. We still need to develop sensitization material. I have talked about the 5As framework, but how are health workers supported to give that information around DSD? What do they tell the recipient of care? How do they discuss and have dialogue so that an informed choice is made, and especially translating it into local languages that will promote all other different approaches. And then lastly, we want to optimize our data elements, as I have demonstrated, on the primary tools that we use for care, but also translating it into data visualization through dashboards and even an online system that can be used, like the electronic or medical records, which would be able to give us a holistic approach and to look at how the program is performing, but taking in mind the patient-centered approach for care. I thank you very much for listening, and I acknowledge all those. Thank you.
Thank you very much. I'd now like to invite to the stage Helder Makul from the Ministry of Health in Mozambique.
Thank you very much. My name is Helder Makul. I'm Care and Treatment Technical Advisor in Mozambique at Ministry of Health, and I'm also focal person for DSD. A brief context about Mozambique. We have HIV prevalence of 13.2%. We have about 1,700,000 people on treatment. They are receiving their services in 1,700 health facilities. It's important to say that about 70% of the recipient of care are receiving their services in only 20% of health facilities. And it's a challenge, and that's why we need to implement differentiated services delivery just to allow better quality of services for those recipient of care. We are implementing our national DSD guide since 2018, and are described in our guide more intensive and less intensive models. More intensive models, we have one-stop models, mobile brigades, clinic, and mobile clinics. We have also a family approach as more intensive model. For less intensive models, we have facility-based model, TREMMD, and fast flow, and community-based models, community adherence groups, and mobile brigades with component of 3MMD. To be eligible for a less intensive model, according to our guidelines, the recipient of care must be established on ART. And we consider established on ART a recipient of care that is viral load suppressed or with high CD4, have good adherence on ART for more than 6 months, without active condition of WHO stage 3 or 4. In Mozambique, we are also implementing adherence clubs that are adolescent groups where we have a mix of patients with good adherence and patients with high viral load. So in these groups, we allow them to share their experience and collect best practices to improve their adherence to the treatment. As I said before, to be eligible for a less intensive model in Mozambique, the recipient of care must be viral load suppressed and have good adherence to the treatment. When a patient is enrolled on a less intensive model and becomes unsuppressed, being enrolled on an individual model based on health facility, he is temporarily removed from the less intensive model until becomes suppressed again. And when he is removed, he receives his services on a monthly basis, including enhanced counseling. And recipient of care enrolled on group models and become unsuppressed, they can still be part of group dynamics, but they receive their services in a monthly basis just to allow them to become suppressed again. Why are we implementing this approach? It's because based on our experience, most of the patients that have elevated viral load, the main cause of this elevated viral load is poor adherence to the treatment. That's why we describe on our guidelines that the recipient of care is temporarily removed from the less intensive model to allow him to receive these services on a monthly basis. Example of community groups that we are implementing in Mozambique, we have community adherence groups. That is a less intensive model that are groups where we have 3 to 6 members. The majority of the members of this group must be viral load suppressed and have good adherence, just to pull the other members to become also with good adherence. And in these groups, if the recipient of care becomes unsuppressed, he must, as I said before, he must go in a monthly basis to the health facility, but he can still attending the group dynamics just to collect experience from the adherent recipient of care. We have other more intensive groups. We have mother-to-mothers groups, for example, and the logic is the same. With COVID pandemic, we made some adjustments in the country. All group models was temporarily suspended. Recipient of care with high viral load received TREM-MD, even having high viral load. We decided to implement this approach just to allow the patients to reduce their exposure to COVID at health facility level. And just to provide them enhanced counseling, we made telephone calls for counseling to improve their adherence to the treatment. We also implemented a CAN treatment one-stop model that consists to provide all services in the same cabinet by the same provider. We implemented one-stop community refill by healthcare worker. For the patients who miss the appointment, the healthcare worker goes to his house and provides 1 month or 3 months drugs to the patient according to the model that the recipient of care is enrolled on. On this graph, what I want to highlight is that recipient of care enrolled on TREM-MD that become unsuppressed and receive enhanced counseling through telephone calls, their viral load suppression is not so different when we compare with the recipient of care that receive their enhanced counseling on a monthly basis at the health facility. On this graph, what I want to highlight is the trend of active patients on ART before and after implementation of one-stop community refill by healthcare worker. With COVID pandemic, we noticed the reduction of the decreasing of number of patients active on ART, but going to their houses and providing the medicines in their houses, we noticed that the trend or the number of active patients on ART started to increase. We are finalizing the update of our DSD guide. In this new guide, we bring has new model, 6MMD, adherence clubs, multi-month drug dispensation through community health workers, and one-stop community drug refill by healthcare worker for more intensive and less intensive model. What I want to show in this slide is that for one-stop community drug refill, if the patient misses his appointment and has high viral load, or missed the sample collection for viral load, he receives his medicine only for 1 month. But if he is enrolled on TREM-MD at his house, he receives medicines for 3 months. Our perspective in terms of manage recipient of care with high viral load in this new guideline that we are finalizing, our approach will not be so different. We will continue with the same approach. Patients with recipient of care with high viral load will temporarily be removed from the less intensive model, receive 3 months of enhanced counseling, and after become suppressed again, he can be again in the less intensive model. For a re-engaged recipient of care, if the patient is re-engaged in less than 60 days after disengagement, he continues in less intensive model if he is enrolled in less intensive model. But if his disengagement is for more than 60 days, he is removed from the less intensive model, receives services in a monthly basis for 3 months, and after 6 months, collect viral load sample where the provider will decide which models may offer to this recipient of care according to his situation. My country in past years are being affected by calamities and military conflicts. That's why in this new approach that we are bringing in 2022, we decided to provide less intensive models in these settings regardless of the viral load, just allow the recipient of care to continue receiving their services even if the access to the health facility is compromised. Challenges, we have many challenges. The main of these challenges are, the first one, the current visits calendar for the first follow-up viral load are not aligned with a clinical consultation. The second one, we are still having gaps in our viral load flow, and we need to work on that. And we are using paper-based systems that do not allow us to capture all relevant information for the right decision making. In summary, we are implementing our DSD guidelines since 2018. We learned lessons with COVID, and we are considering these lessons in our updated guideline. Way forward, consider outcomes of telephonic monthly enhanced counseling with 3 months refill to see whether reducing visits frequency with enhanced counseling supports viral load suppression in era of DTG. For recipient of care that miss appointment, they keep in less intensive model if he is enrolled on less intensive model, and he receives only 1 month if he has, for example, high viral load or missed viral load sample collection. And thank you very much.
Thank you very much, Helder. I'd like to now invite to the stage Ms. Lillian Moreko, Executive Director, founding member of International Community of Women Living with HIV East Africa.
Thank you very much, and good morning, everybody. I don't have any disclosures to make. And as you've heard, this morning we've been able to hear from what the guidance that we have. We've heard from WHO, but we've also heard from our governments in terms of what they are implementing. So I just want to remind each one of us, from our perspective, I bring greetings from the recipients of care in this room. So I want to remind ourselves that when we talk about differentiated service delivery models, from our perspective, we are talking about centering or placing the person who receives the services at the center. But what that means from a perspective is that we are looking at the priorities and needs of this person. But when you look at the implementation, so we don't have a contestation around the guidance, and we appreciate that WHO has come up to really make sure that all individuals in their diversities are taken care of, including pregnant women who for a long time have been missing out. And we are also appreciative that the countries are moving forward to implement approaches that are looking at the needs and priorities of the people. But where we have a contestation, ladies and gentlemen, is at the implementation level. And therefore, as we move, as we get into the discussions, and as we look at these sessions, one of the key areas that I want you to keep focusing on is, where is the recipient of care in all this? At what level do they come in? And therefore, if we are able to address that, then we'll be having models that work and give us the best outcomes that we need. And therefore, we need to look at, when does this person come in? Is it at the receiving end? Is it at the end? Or they are part and parcel of the policy development, of the decisions that are being made? And therefore, when implementation comes, the implementing partners or whoever is implementing is looking at what has been agreed between the recipient of care and the person who makes policies and decisions, but also the person who comes up with a program that gets implemented. And therefore, when we talk about pregnant women, one is that we need to be reflecting a lot in terms of what does it mean for this woman. It is important to remind ourselves that when you're pregnant, or when a woman is pregnant, for those who have never been pregnant, I'm speaking from experience, is that you have that anxiety. there's some excitement, but there's also fear. But importantly, when we talk about HIV, we're also talking about so many issues that this person is dealing with. There are individual issues. Currently, where we are doing test and treat, the person comes with excitement, they are pregnant, and they get here, we are telling them, you need to be tested for HIV, you need to be started on treatment. So they are dealing with all these issues, and how do they fit within the differentiated service delivery models, but also the decisions that we make, where we place them. Do they know? Are they being consulted? Secondly, this pregnant woman may be having other children that they are taking care of. And therefore, what does this mean? But also it may be a woman like me who is working, and I'm therefore dealing with so many issues. What does the society see me as a pregnant woman? And therefore, what does that mean when you think and determine where to place me in terms of where I access services? And therefore, all these issues, including violence that may be going on in our homes. But I also want to bring the voices of women living with HIV in this room. One is that women have said that, for example, they've been part and parcel of pushing, advocating for the differentiated service delivery models to make sure that their needs and priorities are taken care of. So the question they ask is, when they demanded for this and it is on table, how come now you're deciding where they should be and where they should not be? So this takes me back to what I'm saying. Where are these women when we are making these decisions? But also important to note that women make important choices and decisions to the extent that one of them is that if a woman has tested and they know their status, they make hard decisions to say, now I want to be pregnant. So when they get pregnant, again, it's not like they are just becoming HIV positive or they are knowing their status. They have known this long before. They have been in some of these models, and therefore deciding to move them from a model that they have been in for long and putting them in a model that probably will not work for them is one other area that we need to look at. And therefore, these are some of the things that we want you to think about, but also to reflect on choices and options. Who makes decisions? Who makes choices? And who decides for this pregnant woman? But again, in the 2021 WHO guidance, like you've heard, pregnant women have been included. And therefore, we want to call upon all governments and implementers that we don't only work with the guidance, but that implementation follows the same. And of course, we have talked a lot about transition, and I don't want to talk much about it. But the question I want to ask, especially the implementing governments and partners, is when we talk about transition, who is transitioning? In many times and countries and spaces, it is our implementing teams that are transitioning. Actually, the women and men and girls are not transitioning. And therefore, that is very, very important. So let the transition start from the person, because we have said this is person-centered. So let the person be the one to say, I'm now transitioning from here to there, and that is where I want to be. Of course, we learned a lot from COVID, and you have heard. But the question is, are we carrying the lessons that we learned? If we were able to risk and give people medication for all that long, and it indeed worked, why do we have to be going back? Because we are seeing ourselves going back, that even when the policy is very clear, even when the guidance is very clear, we want to go back to our ways of doing things, making decisions for individuals without the individuals. And we are saying that is not right. That will not give us the results that we need. I'm glad Dr. Koderia talked about what is happening in Uganda, and I'm not going to get into that. But I also want to emphasize that for all the countries, for the global community, again, let's make sure that we are placing people at the center and that they are the ones who are deciding on where they want to be. Because you see, one of the key things that I want also to emphasize is that we are not static as individuals. Because you may think that today I may be in this model, but tomorrow I may want to be in another model because my situation has changed. Today I may want to be in a community group where I'm accessing my medication. But tomorrow I may want to socialize and I want to get out of the environment that I'm living in forever. And I maybe want to go back to the facility. So we need to have people at the center, but they should be the ones to tell us what is it that they want. And sometimes some of the things we don't talk about them, but they are real. Because I've been in treatment, I've been receiving treatment, I know the model I'm in, but nobody has ever told me that model. And so when I sit back, I ask myself, but is it like it's me who doesn't know, who doesn't get this information? And I don't complain because I know that the health facility is overwhelmed. So the question that one would want to ask is, where are the people living with HIV? Where are the recipients of care in terms of supporting the differentiated service delivery models that we want? How about taking this back to them and asking them to be the ones in charge of educating, sensitizing, providing treatment literacy to the people, so that when they come like I go, I'm not going to be asking, I'm not going to be challenged, because I know the model that I'm in, and I can ask questions if I want to ask questions. Therefore, meaning involvement of people living with HIV is very, very critical. But it is also important that we follow the guidance that has been given, and we consider how best to make these models work for the people.
Thank you all. We want to thank our very interesting, exciting speakers for this wonderful session. We unfortunately will not have time for questions, but we encourage you to perhaps reach out to the speakers during the coffee break with your questions. And thank you very much.